Good afternoon. Can you guys hear me? Good afternoon, everybody. My name is Byron Orion, the Division Chief of Acute Care Surgery at Robert Wood Johnson, Rutgers Medical School in New Brunswick. We are happy to host a panel session on global surgery in action. What drives you? When you put together a panel, you call upon your friends, some mentors, and some rising stars, and that's what we have on this panel. I won't tell you which one is which, but on the panel, we'll start with, on the left now, it's Dr. Kaplan. He'll be our first speaker, Professor of Surgery at Perelman School of Medicine at UPenn, the Section Chief of Surgical Critical Care at the VA Medical Center. Really somebody who's been influential in my career, always has been a sounding board for me, a big brother, and has guided me throughout since I was a youngster. So I'm very, very happy to have him present to you on remote aid during prolonged humanitarian crisis. Dr. Lewis Kaplan.
Excellent. With that introduction, I think you can figure out I'm the old person in this particular crew. Okay, let's see if this will work. These are my disclosures. For this room, I don't need the microphone. None of these are financial in nature, but you can decide whether I fairly picked evidence that I will present to you today. These are our objectives. Within the context of a humanitarian crisis, we're often driven to want to do things. But how you do that is as important as your desire. So we're going to talk about how people do render aid. What does a remote approach look like? How do you operationalize that? And then how do you grow it? Because that's exactly what we've done. So if we talk about a humanitarian crisis, I want to put those into the WHO cluster. And you'll see at the bottom, there's preparedness, the disaster itself, and response. That flanks the disaster. And people often forget about the recovery piece, which should be linked in some way to the program that you provide to render aid. It's often left out. There are many aid agencies. You may find one of your own here. There's federal ones, non-governmental organizations, medical professional organizations like this one. You might have a hospital team. The University of Miami has a team just like that. And there may be military aid. These are well established. But how you use each of them to your advantage may be different. Let's talk about aid approaches. There are divergent ones. We would like to be in person. We heard in the last session about people that have traveled elsewhere to do aid kinds of activities. It's familiar, it feels good. You can see exactly what you did. It restores your faith in humanity because people volunteer of themselves. But there are risks, especially in war zones. Remote aid, well, that might be much more impersonal. You may feel as if you are not so well engaged. You don't get the same feedback. There's no tactility to it. You may believe that you will be an observer and that you have no risk. These are patently false, and you will see why. How do you get a request for aid? Maybe it's a faculty family member. That's what happened for us. Maybe it's a colleague who is working remotely. Or, like the Society of Critical Care Medicine, they have a portal to request aid. Remote aid is challenging. There are many things that drive you to do this remotely rather than in person. In war, you may not have access. You can't get there. We'll talk about this in the context of the Ukraine. You may not have supplies. It's challenging to do what you do without that. It may be absolutely unsafe for you. Not all of us are comfortable in body armor. Anyone have a military commitment or military exposure?
Military spouse.
Close enough. How do you get time from your job? Right? So are they going to give you time to say, I'm going to the Ukraine? Unlikely. Right? From a professional standpoint, you need permission. Who will deal with your liability insurance? You are generally not covered, and your license may not be valid there. And of course, you have other obligations. But you have to frame this in terms of how your arrival in a country where there is conflict will interface with the government's posture. Do they sanction this or not? Are there policies for that? Are there relationships that will be untowardly affected if you show up there? And as you get older, sometimes Sometimes you have health issues. How will you have health care if you need it? Will your family tolerate that? What happens if your place of employment says, feel free to take vacation, I'm not paying you? And many of us have this well-developed skill set that absolutely relies on a cadre of individuals to help us to do what we do. They're not generally self-reliant. We heard about that in the last session too. Before you think about whether you're going to go or you're going to do it remotely, you must understand the mission. And you will see the 4 things that go from left to right, they are critical. Advocacy is left to other organizations. That's not what remote aid is all about. It is about providing the other pieces in a way that is tangible and embraceable by those who need it. Mission drivers, why do they want aid or need it? Things that you don't see. Complexity that is outside of your skill set, and a management approach that is not intuitive to you. It was not how you were trained. This is a typical patient from the Ukraine. And remember, during the Ukraine war that continues to today, these are civilian facilities dealing with war-injured patients. This is not what they're used to. There is not Walter Reed. There is not the giant urban trauma center that says, oh yeah, you've been shot 12 times? That's fine. I just did that case yesterday. So this is a person who had a mine explosion. Had field rescue, was taken to a far forward hospital, and then was transferred to one of the civilian facilities and arrived in multi-system failure and septic shock. That's the wound from his right flank that you can see. And you can see there's clearly necrotic areas, these very lovely, tiny, delicate plastic sutures. There's more wounds underneath. And so we said, sorry, you must take him to the OR. And of course, the bowel was not at all contained. We had to teach them how to apply mesh, to read the wound, change their lines, added an antifungal, the panoply of recommendations for things that they don't typically see are vast. It is everything from pulmonary care to nutritional support. And you get that, which is now a much nicer wound. Manage that with back, and the other connected wounds that they also debrided also got managed with back. This person survived. But they did not know how to address this. This was from early in the war effort. Now they would not ever ask for guidance because they're much better. So when you design a program to get them from what do I do to of course I do, I already did that. Let me tell you about this other thing I don't know how to do. You have to design it in a way that makes sense. So this was a stepwise approach. We started with the administrative components, added the clinical components, and then made it functional. And you'll see that there's not admin in the way that we think of admin, telling us you have this other paperwork to do, but it's people to coordinate. Someone in authority that can marshal resources from your healthcare system. So our leader was our chief medical officer, who doubled as an ID person. And therefore, everyone had more than one functionality aspect. There was a purpose-built NGO in the Ukraine, and that liaison person worked with one of our admin staff to coordinate all the time. IT became essential, and we'll talk about that in a little bit. Everyone on the initial team was seasoned. No one was fresh out. They'd been there, they'd done that, and most of us have had military experience. We did need a translator up front. But our admin person learned Ukraine, and their lead person spent time learning better English. And then our site didn't need a translator. You can see from schedules and database to what the scope is and whether we should expand, all followed in the wake of those things. And so therefore, what we anticipated was that this would be the flow from all of us to the clinicians there. What we didn't anticipate was that it also went in the other direction. And it took about 6 months. Now, Maher said some very nice things about me. At least one or two of them were true. But for the first 6 months, we knew nothing about any of the people that we were helping. After 6 months of seeing the same team twice a week for an hour at a time, then we started seeing pictures of their kids, their dog. What's happening outside? Here's a shot from my home. Now there was bi-directional feedback, and it wasn't about the clinical pieces, but it was about them as people. We didn't expect that at all. What tools did we use? WhatsApp was great. Whoever developed WhatsApp should be bronze, put it on a pedestal. Zoom, of course, we used. Data sharing across lots of different entities. You see them here. And it was twice a week plus on demand. If you're in the OR and you have an issue, have someone else call whichever the right person is on WhatsApp with a video, and I will talk you through that. 2 a.m. was a really good time to get phone calls. 2 a.m. our time. What helped? We started with one facility and one discipline. This was orthopedics, which is, as opposed to the visceral surgeons there. Military experience, urban trauma hospital, we see these kinds of things in large part. We had the time. This was viewed as part of the mission for Penn. And the development of English language competency was key. Don't ask me to speak Ukrainian, I'm not good at that. What was hard? We didn't know anything about the patients. There was very little that was provided other than imaging and context. 21-year-old injured 5 days ago and had some surgery. So a lot of these were not fresh off of the battlefield. They'd had some therapy. We didn't know who they were, so we couldn't easily keep a list. They didn't have a lot of supplies. They didn't have diagnostic tools that were available to them. Sensitivities for particular organisms that were growing. We had to extrapolate. And some of the specialists that we rely on, oh, would you like to have a microvascular reconstruction for that? Of course you would, but it does not exist. But it was an opportunity to develop that. And those skill sets hinged on having a growth mindset group that already had well-established technical skills. So we expanded the mission. We added more faculty, more consulting services, additional facilities. Supplies came from the health system. We got corporate donors. We sent them a mobile C-arm. You know that is not cheap. To augment the skills that they needed, we created a course over in Germany. So not in the war zone, to teach them microvascular techniques, which is what they need for salvage. We had lots of digital platforms for mentoring. And we have who doesn't have a library of articles, right? Anybody? They didn't have a library of articles. We sent them manuscripts, videos, courses, things that were behind paywalls we got people to donate. And therefore, you could say that's a little of advocacy, but it really falls under education and the cognitive development skills. But you have to do this maintaining operational security. Early in this conflict, people were very concerned. You will find me. You will find where my hospital is. You'll find my family. And you will guide munitions to where I am. So that having all of this encrypted was important. Having their names not appear was essential. Our names could appear. I'm not worried about Russian missiles reaching me, at the moment anyway. We decided the timing was okay. It was a risk in terms of having encryption go back and forth, but it was worth it to save patients. So if you think about, is that real? If you think about Earth orbit visualization platforms, you can get a live 3D street view, and if you have where a signal was originating, you can guide something there. So they were concerned. How do we know what we're doing? We had to make a database. Paper and electronic documents are a disaster, but it was a place to start. Then we moved on to Dropbox, RedCap, but that's really PDF stuff. And you can curate images, but you have to put things in manually. And therefore, when you want to know what did you do, this is a very difficult analysis. We did something else. We went to the National Emergency Telecritical Care Network. And this is a program that was developed in a group fashion early in COVID. Doesn't matter what your EHR is because it's standalone. It is critical care focused, but it's a public and private partnership opportunity that hewed to what the Office of the Assistant Secretary for Preparedness and Response wanted us to do. It has a chart layout. You don't need any special hardware. There's just an app to download. And you don't have to have any relationship at all with the group that offers this. There are 3 different groups that offer this. And it fits right here in the fourth industrial revolution, telemedicine. So it was right for this, and it made sense. It made sense because it's a clinician-based application. And you can see it works on lots of different systems, and it guides communication. It doesn't matter what device you have, it will work on it. We've demonstrated that. It takes the bedside clinician through the app, links them with remote specialists. We were the remote specialists. Made perfect sense. Lots of different applications. We focused on the third, optimizing specialist resources for health systems. And we viewed our health system as the Ukraine, because we knew we're expanding to more than one facility. And therefore, we created generic Ukraine IDs, Ortho 1, Ortho 3. We talked to the designer, they embedded Zoom. One phone call, not two. One access point, not two. Data could be uploaded within that app, and it was stored there, it was curated, we could evaluate it, and it lived in the cloud. And they had operational security, because it was very hard to break into this. We had our IT people try, they couldn't. And they're pretty ingenious with that. This is what the originating clinicians see. So if you are the orthopod in Ukraine, this is what you would have. Only a few data pieces that go in there because it just establishes a chart. What I get is this. And now I have an opportunity to have messages, or e-notes, an activity log. I can send communications. If there are particular things from ID, all that can be put in there. You had them add fields that also include surgery. And therefore, this became important. What were their questions and what were our recommendations? Now they did not have to take notes, because we took the notes and put them in there. And, of course, you can take this and translate this into Ukraine. And therefore, they didn't need an English translator anymore because there's a bidirectionality for the information. Surgical mentoring in the operating room, it's kind of awkward to have someone hold the phone for WhatsApp, and so therefore, we use rods and cones. We got these to be donated, and we sent it to them. And therefore, what they see, we see. And we also get to hear it. It's been used in lots of different ways. There are military applications for it. We're working on extending this to their field medics, so they have some guidance, because they're seeing things for which they are not well trained. These are our partner sites. We started here at Vinnytsia. We then added Cherkasy and Uzhgorod, and now we hold training courses there for microsurgery. We've had 2 additional ones. And we have an online course that now we've trained over 100 of their surgeons in terms of basic techniques. And as we have more courses here, we'll rotate them through the livestock. And we've recently added Odessa, which are seeing many more acutely injured individuals. As of March, 3 hospitals, 5 service lines. You can see them listed there. 358 unique patients, often with additional follow-up. Let me show you how this flap looks. $1 million in disposables. All of the physician services were donated. Talked about the floor device. 180 educational resources. You can see the courses that are listed there. And most importantly, the questions went from what should I do to how best should I accomplish this? These are my thoughts. The movement to independence was key. They just asked about how we replant limbs. That was not on the horizon. When you look at all of the cost here, this is all the people, hours per week, the number of weeks, total time, the FTE equivalent, and when you look at all the physicians, it's about a 0.5 FTE to staff this. So there's a monetary cost to all that. Of course, we don't get any offset for our time. This is just added on. So most of our meetings are at 6 in the morning, which is a great time. Not included in that, all the stuff you do when you're not involved in the consultation, all the impromptu calls. The NGO liaison doesn't work for us, so that's not counted. Translator services, the OmniCure staff that provide the app that have modified it, have reworked the code. And then the in-person courses are completely separate. That's not included in this at all. But this is what happened. Unlikely friends. There's no way I would have ever thought, I'm going to know a whole bunch of surgeons in Ukraine. And now we send kid pictures back and forth with dog pictures. Recipes. Unanticipated. Remote is rewarding, just in a different way. But it also supports these things, the recovery planning. I said that gets left out. That's included in this. Education, exchange programs for faculty and for trainees. Moving towards how they restructure care. Which of these facilities, Pirogov is now a regional resource center based upon what they can do and what their outcomes happen to be. And a dedication to help rebuild infrastructure, that's part of the global health approach. So I'll leave you with these conclusions. Remote aid is much more than what you expect. It's surprisingly personal. And you get deeply invested in the individuals as well as that particular mission. You must know what you intend to do. Technology can be absolutely helpful in facilitating this and overcoming barriers. So thank you very much for your time and your attention.
We're going to take questions at the end of all three talks, so hold your questions to the end, and I have several to lead off the discussion. So thank you, Dr. Kaplan. Moving right along, we're going to introduce the youngest of our group, rising star, as I said, Dr. Kewalramani, research fellow at the University of Pittsburgh. She'll be talking to us on the use of AI in bridging global surgical inequities. I'm particularly excited because University of Pittsburgh tenure is coming to a close as I officially recruit her to Robert Wood Johnson and Rutgers. So she's one of my newest faculty.
Thank you, Dr. Narayan. I think you officially made it official today. Hi guys, my name is Divya Kewalramani, and I've had the privilege of working with Dr. Narayan for a while now in developing this project. Project ACCESS stands for Artificial Intelligence for Comprehensive Care, Equity, and Sustainability in Surgery. I think the mission and the vision of the project are very well stated in its name. I think everybody here has referred to the disparities and the inequities that exist in terms of access to surgical care. 5 billion people lack access to safe and affordable surgical care. That was established about 10 years ago now. And we've done a lot to overcome those challenges, but a lot still needs to be done. The advent or the discovery of AI presents itself as a great opportunity to potentially fulfill those gaps that exist. We developed ACCESS on the realization that we're using these technologies to create predictive solutions for high resource settings when we should be using this technology to create reactive solutions for low resource settings. And on that basis, on the pillars of co-design and collaboration, we created Project ACCESS. To take you through our journey, this is how we did it. We started by creating a patient journey map where we outlined the key processes a patient has to go through to get to surgery and in the hospital. And then we did a survey to identify the pain points that the patients faced. Once we understood the problems, we created the technological backbone of the project, which was the Picasso model. This is a surgical ecosystem where we tried to bridge the problems, the most commonly identified problems, with potential AI technologies and how those solutions would look like. Once we had the problems and potential solutions, we tried to develop an implementation plan to see how we would execute our vision. We then did a preliminary impact and investment analysis to see what resources would be required, if it was sustainable, if it was feasible. And then finally, we picked our first use case, and now we're exploring where potentially we will do the pilot. This is the patient journey map. I know it is really wordy, and but I will try to walk you through it. The top half are the key activities. These activities remain same in both high resource settings and low resource settings. So it entails essentially a patient noticing their symptoms, deciding to seek care, going to their primary physician, getting a consult to a tertiary care center, getting to the hospital, and then finally getting the surgical intervention, post-op monitoring, and then long-term follow-up. We then did a qualitative and a quantitative interview among patients and global surgeons to identify what the pain points were in the journey. The ones that you see highlighted here are the ones that we think AI could fix. Now, there are several boxes here. Some solutions other groups are also working on. Some solutions we want to work on. One commonly identified problem was the lack of supply, as Dr. Kaplan also mentioned. So AI is something that could potentially fix that problem. We are fully cognizant that not every problem in the patient's journey can be fixed using artificial intelligence, but there are some rate-limiting steps in access to care that could now be fixed with AI. Then we created the PCASI model, which is the patient-centered AI surgery expansion model. As you see at the center, the core are the patients. Patients are the North Star of this project. The goal is to improve outcomes, get more access. The pink boxes are the most commonly identified problems. Those were surgical supply chain issues, gaps in patient literacy, scheduling issues and bedding issues, and then finally post-op complication. Monitoring was a big issue. We then tried to bridge these problems by using potential AI technologies. So for example, supply chain. If we create a solution using artificial neural networks, then we could optimize the surgical supply chain. On a patient level, that would look like patients in low resource settings don't necessarily have to stop by a pharmacy to get their own supplies before heading into surgery. On a hospital level, that would look like supply chain and inventory management for the whole department. On a regional level, that would look like surgical resource distribution and forecasting. And on a global level, that would look like demand modeling and crisis planning. If COVID taught us anything, it's that the hospital stopped working without supplies, whether in a high resource setting or in a low resource setting. We then created the implementation plan. Again, I know that it is lots of arrows and lots of boxes. And for the purposes of time, I'm going to skip through this. But the idea here is to collect relevant information, use it, de-identify it before using it, to develop a model which would then optimize outcomes, maybe try to integrate it with the existing systems and then scale. This was the preliminary impact analysis that we did. Everything that you see in red is where potential investment would be required. And everything that you see in green is where we see long-term savings, sustainability, better patient outcomes. In the last, hour, we've heard plenty times that low resource settings don't necessarily mean low and middle income countries. They could also be in our own backyard. And so the goal here is to use these technologies both in rural settings in America and in low resource settings in low and middle income countries. So we're hoping to do a pilot, a concurrent pilot in both. There will be no initiative complete without educating surgeons or creating a new generation of surgeons. And AI is very capable of doing that, either through simulation or skills acquisition and retention, real-time monitoring, and real-time intraoperative decision-making. This is the core of what Access is. These are the 4 potential solutions that we began with. To tackle the problem of lack of health literacy, we want to build a self-triage chatbot. Instead of spitting out a diagnosis, the idea for this chatbot is that the patient inputs symptoms and the chatbot guides the patients towards, you require primary care, and this is the closest primary care clinic by you, or that you require surgical intervention and then that this is the closest tertiary care center by you. The other problem was surgical supply chains, which we discussed in the previous slide, and using artificial neural networks could potentially identify why the surgical supply chain system of a hospital is not working and then optimize and automate it to reduce the administrative burden on surgeons and clinicians in low resource settings. The next one is hospital workflow efficiency. I think all of us that work in ivory towers have seen at least one or two AI algorithms being developed in, I think, the last year. The idea of using this application would not be to do a very high level, high compute optimization and efficiency, but to fix simple problems like staffing and bedding that are still very real in low resource settings. The fourth one is post-op complication monitoring. The idea here is to have provide the surgeon a real-time assistant that will stratify the risk of the patient to, say, develop surgical site infections and then guide them towards the right antibiotic treatment. Of these four, we had several conversations, which I think Dr. Narayan can tell you about, to decide which one we should start by doing first. But we decided to do the surgical site infection post-op complication monitoring one, realizing that surgical site infections has a massive burden, not only on the United States, where we spend up to about $10 billion fixing surgical site infections, but also more so in low and middle income countries. It's costly to the patient, it's costly to the hospital, and it ends up with a higher mortality and morbidity burden. To that end, we developed, or are trying to develop, the surgical site infection model. It has two aspects to it. So on your right is the patient interface. The patient interface is developed to collect patient data, wound images data specifically, through a smartphone app, which would also then collect patient-generated health data. It would have a 5-question survey, which would ask for temperature, how the patient is feeling, and then as an output, it would provide whether your wound is infected or not, and how to use your antibiotics and discharge summaries and all those educational components of it. On the physician side, what it does is threefold. One, it looks at your patient and immediately post-surgery and identifies whether your patient is at a higher risk or at a lower risk of developing surgical site infection while the patient is in the hospital. So we have a better chance of intervention. Then you could open the wound, or you could change the course of antibiotic, or even give them prophylactic antibiotic, which would hopefully reduce the burden of surgical site infections. The second thing that it would do is predictive prescription. There isn't any other model that exists right now which would tell you which antibiotic is the correct one. While developing this, I realized in speaking to everybody that a lot of surgeons, a lot of physicians and clinicians don't realize that there is a hospital-specific biogram that is used for prescription. And that made me realize how escalated the problem of antibiotic resistance was and how we were all contributing to it. And it would significantly reduce the burden on the physician, and it would be a great step towards antibiotic stewardship if we could develop a model that would tell you exactly whether or not a patient requires antibiotics. If they do, which one do they need and what the dose is. And then finally, because there is a surveillance aspect through the patient interface, the physician could always keep tracking what the progression of infection is. The goals and targets for access are still evolving, but the idea is that in the next 5 years, we want to develop this model, validate it internally and externally, and then hopefully maybe even apply for a 510K, software as a medical device, while all keeping it open source to the population that needs it the most in low resource settings. Internationally, we have spoken to multiple administrations and surgeons across the globe to see who would be interested. These are the sites that we have gotten preliminary acceptances from. Locally, we have spoken to the Indian Health Services, and they seem to be very interested in running a pilot there. In conclusion, the idea for Project Access is that we want to redefine surgery as a high-impact, highly affordable solution. One, keep it open access because the need exists. Second, design our interfaces in a way where technological savviness, literacy even, shouldn't matter. Keep it multimodal, so the inputs could be patient-generated health data, data from the surgeons, data from EHR, patient pictures, keeping it low cost and scalable as any solution made for global health requires to be. To end, I would just like to say that nothing could be done without co-designing these solutions. We want to be more participative, less prescriptive. We want to make sure that there is a behavioral component involved when designing these solutions, so we understand the patients more, give them a seat at the table. And then lastly, I wouldn't be here without Dr. Narayan, so thank you. And my really, really wonderful team. It's a very diverse team. They've had great experiences in surgical AI, in ethics, in trauma surgery, in the ICU, in just the tech side of it. So it's a diverse team, and they've spent countless hours helping us build this project. So I'm grateful to them. And finally, the stellar advisory committee that we have between ACS and the Global Surgical AI Collaborative, AAGS. We've had massive support from the industry as well, so I'm grateful. And on that note, thank you for your time and for the opportunity.
Thank you, Dr. Kewalramani. I'm biased, obviously, because I'm recruited here, but hopefully you'll ask her tough questions at the end of our session. The next speaker that I want to introduce before we open it up for Q&A, I told you that we had a big brother, a mentor, a new trainee who's coming up through the ranks, and now a colleague, and somebody who I respect and admire. Watched her work over the years. I know we had a chance to invite her for another conference this past summer. This is Dr. Zoe Maher, Associate Professor at the Lewis Katz School of Medicine in Temple, an expert in global surgery. Her title is Global Surgery, Specialty and Evolution and the Future of Collaboration.
Hey everybody, last talk of the day. You all still have a little energy left in you. I am going to kind of breeze through these slides because I am aware of the time and what happens at 6 o'clock. I think everybody turns into a pumpkin in the room. I'm the Director of Global Surgery at Temple Hospital, and I was a former surgical resident there. And this is like the first 15 slides. I'm just going to kind of tell a story. So when I was a surgical resident, I was very interested, as many of your trainees are, in sort of engaging in global surgery. This came on the backdrop of engaging in global health as a medical student, and I really felt that I wanted to build a skill set and a knowledge base that would allow me to participate and integrate global surgery into my career. And you'll see some slides on this, but the Temple in 2010, I was supported as the first surgical resident to actually participate in our global surgery program. At that time, our global surgery program was permission to do whatever I wanted to do. Now, that is not, I'm in charge now, somebody else was in charge of me. I would never give myself permission to do whatever I wanted to do today. And that has to do with a lot of the learning that I've done, sometimes the hard way over the past 15 years. and some of the evolution that we've all seen happen in the field of global surgery as a whole, and the recognition that generational shift, globalization, and sort of the needs and priorities of learners and faculty all have to be weighed into equitable, sustainable partnership. I have no disclosures. That's what we're going to talk about. You're all familiar with the fact that global health is not a new topic. Global surgery is not something that's been included historically in the conversation. And it needs to be, because a lot of the population has no access to surgical care. Why is it excluded? Well, it's complicated and it's costly. But that's actually, that was a fabricated story that we were all told about the role that surgery has in the global public health agenda, really driven probably by misinformation being propagated. We know that surgical interventions are highly cost effective in a lot of low resource settings. And we're doers. How many people in the audience are surgeons? Right, like, so a lot of people. When you interview someone for a surgical residency, many people tell you the reason they want to be a surgeon is because they want to be able to fix a problem. I see a problem, I want to fix a problem. And that actually creates a bit of a problem for us in the global surgery context, because the way that I think many of us, myself included, thought we should see the problem and fix the problem is by going and doing surgery. And this drove this robust response with short-term surgical and medical missions, which are well-funded. They have inherent benefits. You can all see what the benefit is. But there are risks. And I think early on, and still maybe, people don't recognize the risk that is inherent in short-term relationships. And I think the most important of the many risks inherent in short-term relationships is the fact that you are not addressing the elephant in the room. Because the elephant in the room is that there are not enough people to do the work that needs to get done. And I know I'm talking to a population of peers who are all involved in doing this work. You see that the dearth of skilled care leads to either no care or low quality care. And for most of the population, this is a map of the world obviously, where sort of like less than 20 per 100K surgeons that's kind of the sweet spot, the minimum sweet spot for most regions. And that number is in that sort of medium shade green. You see that much of the world doesn't have access to the staff, let alone the stuff that is necessary to provide high quality surgical care. So we in our program have sort of evolved in our thinking about how we can engage in a meaningful way to train medical students, residents, collaborate with our faculty. People have enthusiasm and excitement for this field, and they want to have an immediate impact. But that is actually not the long game. The long game is actually a long-term solution. So we have sort of been shifting our focus in our program toward workforce development and task sharing. And this is important because we are training the first generation of digital natives, right? So our trainees right now, if you're training residents, medical students, these are people who have had access to data, to sort of conflict through war and community violence, recessions, the changes in environment. And they are people who will tell you that they care about others because they have seen others in a way that at least, I didn't see other people because I didn't have access. And many of the people who are older than myself in the audience can think of a time when the internet was not a thing. So you didn't really know really quickly what was going on in the world. This generational shift in our learners has partially driven this demand in training for global surgery opportunities. And you can see that programs, residency programs in the US have responded by integrating global surgery programs into training. In 2015, 10% of all programs had a global surgery component. Now 60% of all surgical residency programs report that they have a global surgery opportunity for their learners. And 93% of all program directors say that it's important. But what does that mean? What is an opportunity and what does it being important mean for people? We are trying to contextualize this in our shop in terms of academic global surgery, which is like an emerging and now recognized specialty. And we are trying to actually grow learners who will ultimately be able to integrate all of the skills and knowledge that are necessary to potentiate the impact. And I think it's important to say that in doing this, I work in a high resource setting. It is Temple Hospital. And, you know, in Philadelphia, it happens to be a low resource setting compared to resources in some other places. But, you know, in terms of global context, it's a high resource setting. And, you know, when we first started partnering with our partner, which is in northern Ghana, which is in an LMIC, but in a region of the country where they're very resource limited. We brought, you know, some funds with us, some ideas with us, and quite frankly, we brought a lot of power and sort of didn't recognize the danger that bringing the high resource to your partner stakeholder can have. Because if you're not careful, you can fall into the trap of not following these guiding principles when you're developing programming. And I will tell you, I think a lot of surgical residency programs, that 60% of all training programs in the US who have a global surgery opportunity, are still functioning under the let's go do some cases in a place with no electricity or running water and come back and tell some stories. This is not how you solve a problem. So, you know, and we're sort of bound a little bit at these sort of like academic high resource centers to help solve the problem, because there's not only trainee interest, there's also substantial faculty interest. This is data published from the 2015 Operation Getting Back survey, and it shows that, you know, while you have about 55% of all surgeons who responded to the survey who have said they previously volunteered doing some sort of international surgical care, when you look at who says they're interested in participating, you're well above 80. And so there's at least espoused interest. So how do you leverage the interest, the excitement, the skill set of people within the context respecting the partners that we have? So this is sort of our journey. You know, the MDGs were, I'm just going to talk about that, but the MDGs came out in 2000. We were sort of excluded surgically. In 2008, Paul Farmer, who was mentioned here, and Jim Kim wrote that sort of famous paper calling surgery the neglected stepchild of public health. And in 2010, Temple actually had our first year of partnership with the Tamale Teaching Hospital in northern Ghana. How did this happen? Again, somebody said, you can do it, and I basically cold called a faculty at a hospital in northern Ghana and said, would you be willing to allow me to come there and do a clinical rotation? Now again, I would never permit our residents to do that now, but that is how it went down. And they said yes, and off I went. I will tell you that this is a story about the dean at Temple. She's now a dean, Dr. Amy Goldberg. She gave me her credit card when I went. She was my residency program director at the time. She gave me her credit card and $200 in cash, and she told me that I had to take it, you know, just in case. And I'm like, Dr. Goldberg, I'm not sure what you think I'm going to do with like $200 US and your Amex lap, but okay. So I carried it in a fanny pack on my person so that I could be sure I would return them both and hold to her when I came back. And I did come back, and that's probably why she trusts me to shepherd forward our program. So in shepherding forward our program, I became faculty at Temple in 2015. That's when the SDGs, the WHO, you know, Surgery is Essential, and Lancet Commission all came out. That was a busy year in global surgery. And, you know, our program evolved a bit after I came back as faculty. We sort of started to layer in this concept of education, clinical care, and research, and then sort of a pie chart of advocacy for our residents to actually advocate for funding for global surgery. But it was incomplete, and I'll tell you a bit more about that in a second. I want to tell you just about our partner institution, the Tamale Teaching Hospital, which in 2008 was a district hospital, but was basically told by the government of Ghana that they would become a teaching hospital because the University for Development Studies, which is the 6-year medical school in northern Ghana, did not have a teaching hospital to partner with. And so overnight, this hospital went from a district level hospital, and if you've worked at a district level hospital, it's very different from a teaching hospital. So overnight, went to being a teaching hospital with none of the resources that should come along with that. And it has taken this health system a long time to sort of dig out from the strain that put on the health system. This is the hospital as it currently exists. It is a modern facility. They have an A&E, they have obstetrics and gynecology, they're orthopedists, neurosurgeons. It is a true quaternary care facility for the 3 northern regions of Ghana. The catchment is millions of people. There's me there in 2010. This is Kewalramani, who's currently the chair of the Department of Surgery at TTH. So he has tracked right along with me. And this is our most recent resident who traveled to Townland Teaching Hospital, standing alongside 4 Ghanaian surgical residents, because the hospital has developed a surgical residency training program and fellowship. And not only do they have really stellar medical students, they have stellar surgeons in training as well. And here's Prof. Tabiri, who's now Dean Tabiri. This is most recently when I was at our partner site, and this was to discuss our joining something called AMPATH, and that's what I'd like to kind of finish with. So, you know, we are, as an institution, Temple does not have a lot of money to take care of our patients, and you might work in a place that's like that too. So the idea that you would be able to institutionally fund some sort of like equitable, bi-directional, like, you know, perfect relationship, it is not, it's a hope, it's not a real thing. So we've been able to leverage some philanthropic support to fund our joining as a consortium member, AMPATH Global. And this, you'll see here that Ghana is listed as one of the sites. The reason this happened is because Prof. Tabiri, right here, called me and said, hey, listen, Zoe, we're joining AMPATH. They've asked us to be the academic center that is partnering as University Development Studies in Ghana with NYU as the anchor in the United States, with on the high income side in AMPATH. So we are going to become the anchor site in Ghana. And I would like you guys to join at Temple for a few reasons. 1, I know you. 2, I trust you. And 3, because it is so hard for us to partner with multiple different organizations who are trying to do good, want to do good, but quite frankly create strain on the system, because the system does not have anything left to give at TTH. There is one general surgeon there. It is a very high stress environment for people who are trying to provide surgical care. So we are in the process of joining AMPATH Global. I don't know if anybody's familiar with it, but it stands for the academic model providing access to healthcare. Started with Indiana University and Moi University in Kenya. It's a 3-year collaboration. It's actually Nobel Prize nominated multiple times because of the success that they've had. They start with care, so it's provision of clinical care through partnering, but have gone on to be, you know, multi-million-dollar NIH-funded relationships as well, kind of looking at the data, building the data to support how you can structure a relationship for it to be successful for the people that you're trying to care for. And it's this consortium of university partners in the United States and Canada, academic health sciences institutions in the partner locations, with partners in Mexico, Ghana, Nepal, and Kenya now, and then really partnering through the public sector health system, recognizing that without governmental buy-in, nothing will last. And so I just want to kind of come back to our program. You know, we have tried to allow the reality that we live in to influence how we have developed and changed our training program. My goal, and global surgery is integrated for all of our residents, it's required curriculum, but they don't have to actually go out of country. So they have required curriculum integrated into the residency, because if you want people who are global citizens, they need to really understand a lot of the sort of fundamental tenets that we're trying to address. And so now we have layered in collaborative surgical conferences. I love the comment about WhatsApp. You know, we have, WhatsApp is great, but I think Facebook owns it, so I just want to say that. They don't need any more money. We shouldn't give them any more money. But we do collaborative virtual conferences with our surgical trainees in Ghana. And we're starting to layer in surgical trainees at NYU as well, which is really exciting. And then we've actually just started to work on an in situ simulation program at Townland Teaching Hospital, looking at a model of hemorrhagic shock in the accident and emergency department. We have a pretty robust in situ simulation program, which I actually stole from my fellowship at Penn. Kaplan is me, and it's steel, I guess. But we've been doing in situ sim in our spot for a long time, and our colleagues at TTH came to me and said, like, hey, we want to get better with hemorrhagic shock recognition and early intervention, and we think in situ simulation is the right fit. And it's really exciting to kind of see where this sort of thing is going to go. to Dr. Kaplan's point, this can be done, like I do almost all of my work virtually. I don't do a lot of my work on site clinically because I am trying to support the sort of, I don't need to go there and do cases. It's that kind of relationship, that kind of partnership. So again, I'd like to thank you all for your time, and I'll be happy to take questions.
Thank you very much, Dr. Maher. I want to lead off. We're going to ask at least one question of each of you, and then we'll open it up. As a trauma surgeon, we don't play God. I'll give you a scenario. A criminal shoots a police officer, and the police officer dies. The police officer exchanges fire. The criminal has 8 gunshot wounds. He comes to your trauma bay. We operate. Let me give that as the backdrop for my opening question to Dr. Kaplan. I'm teeing you up.
I'm always worried now.
Penn has gone to Ukraine, and clearly there's a crisis when you have one country who is trying to overtake another country. Let me ask remember, as my old boss used to say, and Dr. Newman will appreciate this, he used to say, the issues are controversial, not me. What about what's happening in the current state of affairs in Gaza? Has Penn reached out to the humanitarian crisis there and done remote training? That's part A of the question. Part 2 is, what if you work in an institution that's not Penn? You said that it requires buy-in. And I'm a young trainee who's interested in global surgery, international medicine. But my chair, my division chief, my chair, my dean say, give me the ROI. Because time, if it's your time, you're waking up at 6 o'clock, 2 o'clock in the morning, they want to know what's the ROI for me. And sometimes in this money-driven era, we're running out of money, people can't go to conferences. I'm lucky to come to this one. You get $2,500 a year. Everything is strapped. They want RVUs, RVUs, RVUs. Your thoughts from those 2 loaded questions. And please use the mic.
I don't need a mic for this.
Okay, fine, go ahead.
So, when we got involved in the Ukraine, we had an invitation. We were asked to help. We did not go look for a place to provide aid. At this point, we're wholly invested in the Ukraine. If we were asked to aid there, would we stand up people? Yes. Just like we would take care of the person that killed the police officer. Now, he did that. He had that scenario because he knew that I was a surgeon involved in a regional SWAT team, and those were exactly those ethics. Would I take care of the person that killed one of my cops? And I thought of my cops. And the answer is, of course, yes. We don't get to decide. The ROI is an easier question because it is exactly what brought all of you here. It is why you do what you do. It is experience, it is training, it is perspective generating. It asks you to be more than what you are on behalf of someone else. That is in large part why we do what we do. It is not for us, it is for others. There's productivity, the academic, whatnot, but it is the rest of it that builds surgical character, or gastroenterology character, or ID character, whatever it happens to be, that you will never get outside of that context. That's the easier question.
Okay, excellent. Dr. Kewalramani, next question is for you. The buzzword in surgery is AI. You can't talk about surgical innovation without using AI. Is it the panacea or the cure-all, be-all, end-all for solutions? And can you speak a little bit about the ethics? Are there ethical issues on the horizon if we don't do this correctly? Your thoughts?
That is a great question. I think ethics is variable to every place. So what United States stands for in terms of AI ethics is very different from what the Global South is looking for. while we've been focused for the past year on developing a regulatory oversight for AI, Global South has been wanting to use these initiatives and fix the problems that exist. And while there are definitely ethical concerns, there is always exacerbating the problem versus fixing it. I think that if we use it in a way where we design it together in